Hi. We're currently live. Thank you all for joining us today. I'd like to thank the audience for joining us today for our discussion on the South Sudan Women's Intellectual Forum. We're streaming live on Facebook and on YouTube. My name is Dr. Anne Lomole, and I will be your moderator today. I'm a pediatrician and an infectious disease consultant. Today, we're going to be discussing a very important topic. We're going to be discussing about maternal, neonatal, and child health. We're going to talk a bit about a definition of these terms, what they refer to. We'll also talk about some of the causes, the risk factors, the policies and the programs in place, and the challenges that are experienced in providing care and reducing mortality, especially in the context of South Sudan. Now, according to the WHO statistics of 2017, about 810 women die each day due to pregnancy and childbirth-related complications. 94% of all these deaths are in low and low-middle income countries, of which South Sudan is one of them. And most of these deaths are preventable. In fact, what they have noted is that the people who face the highest risk of death from childbirth and complications of pregnancy are young adolescents. And we know that our country, in our country, it's quite common to see children married off at a very young age. So this high number of maternal deaths is usually a reflection of inequalities in access to healthcare and quality health services. Skilled healthcare would prevent most of these deaths and would prevent the complications related to childbirth, especially because they would ensure that these high-risk pregnancies are identified early and these mothers are attended to as they should be. Now, neonatal mortality goes hand in hand with maternal mortality because the care is closely linked. And the sub-Saharan region has been seen to have the highest rates of neonatal and under 5 mortality. It's particularly important, as we said before, that these births are attended by skilled professionals, because if they are attended by skilled professionals, then most of our children will not die. Child mortality is mostly attributed to communicable diseases, birth complications, respiratory illnesses, diarrhea, malaria, and malnutrition. South Sudan is considered very high on what they call the Fragile States Index. So this is about 15 countries that have been assessed in terms of 12 cohesion, economic, social, and political indicators to show their level of susceptibility to instability. And South Sudan ranks highest in these countries. Because of this, there is a contribution in terms of instability to the deterioration of population health and challenges in stabilizing systems. And the thing that suffers most is maternal and neonatal and child health, which usually deteriorates during a period of conflict. And this largely reflects the situation that is currently ongoing in our country. Investing in maternal child health contributes to poverty reduction, and it also contributes to economic growth and more stable societies. So the consequences of increased maternal mortality and neonatal and child mortality are very far-reaching, and it goes to the level of actually affecting the stability of our societies. We hope that this discussion will start the talk on how to improve healthcare for our mothers, our newborns, and our children. Thank you for joining our discussion today, and feel free to share the discussion that we're having on our Facebook, on all your social media platforms, and also the discussion on YouTube on all your social media platforms. We welcome any questions that the audience may have. We will try as much as possible to answer them. And for those that we're unable to answer, then our panelists have graciously agreed to answer after the session is over. I would like to first and foremost thank our panelists for joining this discussion, for taking their time. And I would like to thank the audience that is currently joining us to listen to this conversation. I would also like to thank UN Women for their continued support, and thank Aisha for the technical support of making sure that this show is live streaming both on YouTube and on Facebook. Now, I will go straight into the introductions, and I would start with Miss Sunday Imanu. Unfortunately, she has been unable to join us due to personal reasons, but I will introduce her in absentia. I hope that at a later date and in a future discussion, she will be able to join us. She was to discuss some of the policies related to maternal health care and what the ministry was doing to work on reduction of maternal mortality. Ms. Sunday is a director in the Directorate of Sexual and Reproductive Health, and she has training in public health and in sexual and reproductive health. She has over 13 years experience in reproductive health issues, and hopefully one of these days we'll be able to invite her on another panel to be able to discuss some of these very important issues in terms of policy in reduction of maternal mortality. Next, I would like to introduce Dr. Idioro Joseph. Dr. Idioro is a practicing obstetrician and gynecologist. She currently works at the Mater Hospital in Nairobi. She has a bachelor's degree in medicine and surgery from the University of Juba and a master's of medicine in obstetrics and gynecology from the University of Nairobi. She is currently pursuing her fellowship in gynecological oncology in the University of Nairobi. Welcome, Dr. Idioro. Next, I would like to introduce Dr. Alice Johan. Dr. Alice is a consultant pediatrician. She obtained her master's in pediatrics and child health from the University of Nairobi and a bachelor's degree in medicine and surgery from the University of Juba. She currently works at Al Sabah Children's Hospital and is also the director of child health at the National Ministry of Health. She is a lecturer at Juba University and the department head for pediatrics and child health. Welcome, Dr. Alice. Next, I would like to introduce Dr. Grace Joan Sommer. Dr. Grace is a pediatrician, a child health specialist, and a training consultant. She has a bachelor's degree in medicine and surgery from the University of Nairobi. She also has a master's degree in pediatrics and child health from the University of Nairobi. She has another master's degree also in tropical pediatrics from the Liverpool School of Tropical Medicine. She has worked as a lecturer in the Department of Pediatrics and Child Health in the University of Juba and at St. Mary's College. She currently serves on the editorial board of the South Sudan Medical Journal as an editorial assistant, a peer reviewer, and an author. She is currently working on writing clinical guidance reviews on nurturing newborns in South Sudan with a focus on essential newborn care practices. This is the first in the series of newborn care clinical guidance reviews from the South Sudan context, and she's keen on capacity building for health workers and has been a recipient of several scholarly awards, and she is open to mentoring and coaching South Sudanese girls, women, and youth who are seeking out opportunities for the same. So welcome, Dr. Grace. Next, I would like to introduce Dr. Lucy Meseka, who is a consultant pediatrician with over 4 years experience in pediatrics and child health. She obtained her Master's of Medicine in Pediatrics and Child Health from the University of Nairobi and her undergraduate degree in Medicine and Surgery from Upper Nile University in Khartoum, Sudan. She also has training in tropical and infectious diseases from the Southern Medical University in China and training in pediatric critical care from Hunan Children's Hospital in China. She is a former consultant at the Al Sabah Children's Hospital, and she currently works with the WHO as an emergency nutrition officer, supporting inpatient treatment of children with severe acute malnutrition. She is also a part-time lecturer at the University of Juba College of Medicine and an executive member of the South Sudan Pediatric Association. Thank you so much, our panelists, for joining us. We welcome you, and we are grateful that you're taking your time to speak to us today on this very important topic. So we'll go straight into the discussion, and I will start by asking Dr. Idioro a few questions. We'll start with the mothers. So Dr. Idioro, if you could unmute yourself. The first question goes to you. If you could just go into a brief overview of what maternal mortality is and what the rates are in South Sudan in comparison to the region and to the world in terms of the statistics. And we have heard of what is called the human rights approach to maternal care and how it can help to reduce maternal mortality. If you can expound also on the human rights approach to maternal care and why it's important. Thank you.
Okay, thank you for hosting me today. Hi, everyone. I just have a disclaimer to make. Due to my experience, most of my presentation is going to be based on examples and real life stories. But of course, because I didn't seek any consent from the people I'm giving their stories, so I will not mention names or tribes or anything of that. It will just be anonymous. Going into the point, maternal mortality is actually described as a death of a woman during pregnancy or after delivery until 42 days. That is the WHO definition. Because actually it takes 6 weeks for a woman to recover completely from her pregnancy state. And again, it relates to any pregnancy, whether it is miscarriage or any type of miscarriage that happens, or any complications of delivery or any complication that is related to delivery. So all that one, we include it as a maternal mortality. Whether the pregnancy is viable or not viable is still, that is related to maternal mortality. Maternal mortality in South Sudan is actually one of the highest mortality rate in the world. And we have a rate of up to almost 800 per 100,000 women. So this is actually too high. If I compare it with Kenya, which is about 370 there, so I think we are double what is happening in Kenya, our neighboring country, and in Africa at large. About human rights, I don't know how people describe human rights, but I think human rights is your own rights. Human rights, you don't have to wait until something happened and people start demonstrations and you join. No, human rights starts with you. Like if there are young girls here who are not yet married, that is where human rights starts. You have to start making a decision early, and the person you are marrying have to know that you have a decision making in the relationship. This one, I can assure you, will reduce our maternal mortality. So if I'm to talk about reducing maternal mortality, I will say financial stability or financially stable woman can be able to make their own decision. But once you are financially paralyzed, I'm telling you, somebody will tell you, no, you have to go to this health center. You have to go there, which actually you know very well. In that health center, I will not find the actual care that I need. I can start by giving a story of women taking decision in labor. I had that mother in labor, and we were there from a tribe who actually don't believe in surgery. So I told the guy, she needs a Caesarean section. And he told me, no, madam, let's give her time. I told him, I'm giving you 30 minutes to make your choice. Or otherwise, I will sign a consent and I'm ready to stand in court why I did the Caesarean. Then he told me, even in the village there, women can stay for 2 days without giving birth, and they will finally give birth after the 2 days, and the baby is okay and they are okay. So I told him, that is in the village there. When you go back to the village there, you do that. But with me here, you are not going to do it. So you sign the consent, I'm taking the lady now to theater. So finally, he saw that I was tough on him and he signed the consent. I went to theater, I removed the baby. It was deep transverse arrest, a baby boy. When I came out, you can't believe that same man who was celebrating all over and running to the finance office to pay the bill. Then I asked him and he was like, thank you so much, Daktari. Then I asked him, do you know that this baby, even if we wait for 1 week, this baby was not going to come out? And he said, no, leave that alone. Me, I'm now happy, my baby is out. So you can see and the women actually give time to the men to come and give the consent. So, and some women, they come to labor and they know their rights. Like another one was in labor, then I decided to ask, because in their community also, they like that issue of the man coming and sign part of the consent. So I asked her, where's your husband? She told me, Daktari, if it is about doing for me a cesarean section, why are you asking for my husband? Give me the consent, I sign, I'm going to theater. So we signed the consent and she went. The husband came when already the baby is out and she's out. The husband was not happy because they believe all African men are the same. Like somebody will say, I know they are the same, but why do you have to try all of them to know that they are the same? Their mentality is all the same. They believe in women pushing, and you are not able to push. Now, I always advise women, cesarean section was made not for somebody else, not in the old age. Cesarean section was made to help, to rescue. Those who are not able to push can be saved by cesarean section, and they're all babies. When you see them playing outside there, you will not even able to pick that one was born by cesarean section because they are inferior, and the other one is born by normal delivery. So women have to know their rights in the first place. If you don't know your rights, nobody will know it for you. Thank you.
Thank you so much, Dr. Idioro. I think I like the fact that you approached it in a personal way in terms of what you have experienced in practice. I noted from what you've said that our rates of maternal mortality are actually very high, and compared to those in the region, we are almost even at double, if not triple. And the fact that you have mentioned that financial independence and empowerment for women is important so that they can make some of these decisions. Information and education is also important so that they know what is needed to be done in particular situations. And the fact that women, if they're aware of their rights, then they're able to seek care when they need to and even make the correct decisions. I think most of us can agree that for those of us who have worked in healthcare, that we have come across those situations where us as women decide that we cannot make decisions, we have to wait for our husbands, and this leads to delay and can lead to death, both for the mother and the child, and that is a very unfortunate scenario. You've talked about cesarean sections. We'll go into the details of that a little later, where you'll be able to mention for us some of the indications and some of the danger signs to watch out for. I will go straight ahead and talk, Dr. Lucy. The next question will be for you. You can unmute your mic, Dr. Lucy. Dr. Lucy, the next question is for you.
Yes.
Thank you. Dr. Lucy, could you please define for us what child mortality is and what the state of child mortality in South Sudan is? If you can also compare it with the region, if possible, and worldwide, and tell us what exactly are the disparities in that comparison, and why would South Sudan be more affected by some of these disparities that we can see in terms of the rate of mortality in children? Thank
you. Okay, thank you so much, Dr. Hannah. And I would like to say good morning, good afternoon, and good evening to our viewers all over the world. And I will just go straight in defining what is child mortality. So child mortality basically refers to a death of children under 5. And we also have that child mortality rate. So child mortality rate is also known as under 5 mortality rate. And this refers to probability of a child dying exactly at the age less than 5 years and expressed or compared to 100%, 1,000 life births. And then also, because we have this child mortality basically talks about mortality under age of 5, we also have the infant mortality. So infant mortality refers to death of children who are from first month of life to 11 months of life, or those who are less than 1 year of age. And then we also have mortality, neonatal mortality. And my colleague, Dr. Grace, will take us through neonatal mortality. And basically, neonatal mortality is any death that occurs in the first 28 days of life. So, globally, an estimated 5.3 million children under the age of 5 died in 2018, and approximately 82% of this mortality happens in two regions, of which Africa and Sub-Saharan Africa is one of them, and then we also have South Asia. And Sub-Saharan Africa covers for 54% of this mortality in under 5, and 28% is in South Asia. So worldwide, the mortality for under 5 is 39 per 1,000 live birth. This is basically from the data of 2018. And the mortality rate in the children for age 5 to 14 years, basically we're talking about 5 until the age of adolescence, it's basically 7.1 death per 1,000 live birth. This is global or worldwide. And in Sub-Saharan Africa, under 5 mortality is 78 deaths per 1,000 live birth. And most of this, it's basically can be explained like the death occurs 1 in 30 and 13 children, and it's basically 15% or 15 times higher than the global mortality. And let's come to South Sudan mortality or under 5 mortality. So child mortality or under 5 mortality still remain one of the major public health problems in South Sudan. Still, as we had as we have talked of global, and then we also talked of Sub-Saharan Africa, and then 15% of this mortality in South Sudan are due to preventable and treatable causes. So, according to the national data, the under 5 mortality rate is at 93 per 1,000 live birth in 2018. And infant mortality runs at 63.2 per 1,000 live birth, with 1.8 decline from the data of 2017. And then also neonatal mortality runs at 39 per 1,000 live birth in 2018. Yes. Okay. So 25% of these deaths is in children under age of 5. That occurs in South Sudan, as it's basically occurs in the neonatal period, and 70% occurs in the first week of life, of which Dr. Grace will take us through it. So mortality comparing South Sudan under 5 mortality to Sub-Saharan Africa and to the neighboring countries. South Sudan is the leading cause of under 5. South Sudan is the leading under 5 mortality. Have under 5 mortality rate more than the other neighboring countries. Comparing to Uganda, in Uganda there's it's 64 in 1,000 live births. So in comparing also to the other neighboring countries or the East African countries, South Sudan is still remains the leading mortality in the region. So also we need to compare ourselves to the SDG. So the Sustainable Development Goal for 2030, from 2015 to 2030, the mortality rate. So the aim or the standard, the SDG 3 is basically talking about the improving health, promote health, and improving well-being. So if we are comparing ourselves to the standard, the Sustainable Development Goal, so for neonatal mortality and infant mortality, we're still very, very far. So the target is that the mortality rate at least should, in neonatal period, the mortality rate should reduce to 12 per 1,000 live births, of which from the data that I've shared, we still have South Sudan is at 39 per 1,000 live, 39 deaths per 1,000 live births. So we are still very, very far from the target. So, and then the 5 mortality rate is at least we need to come down by 25 deaths per 1,000 live births. So if we are comparing this to South Sudan data, of which we are still having 93 deaths per 1,000 live births, we are still very fast. So we need to have a lot of interventions, at least to come down from the mortality of 93 nearly to 25 deaths per 1,000 live births. So thank you. Unmute your.
And we are not
We
hearing you.
can't hear you. We can't hear you.
We're not hearing you.
We can't hear you. We can't hear you. All right. I think I'm just going to carry on as Dr. Ann tries to get herself back online. So I'll be talking about neonatal mortality. I'm sure you'll be hearing a lot of terms flying around. You'll probably hear neonate, newborn. I just want to say right from the beginning that neonate and newborn, it all refers to the same. And as Dr. Lucy has said, the newborn or the neonatal period is the period from birth up to until 28 days. So neonatal mortality would then be the probability of dying in a newborn, that's a child between birth up to 28 days, per 1,000 live births. So she had mentioned it earlier, so I'm just repeating it. So it's important for us to look at neonatal mortality. Globally, the neonatal mortality rate is 18 deaths per 1,000 live births, and that is as per the 2018 data, from which Dr. Lucy was also able to get her data from. Now, when we're talking about global neonatal mortality rate, 2.5 million deaths occur in the first month of life, all right? And of these 2.5 million deaths that occur in the first month of life, 1 million occur on the first day of life, and the next 1 million occur in the next 6 days. So you can see that the first week of life of a baby is one of the critical periods. And loosely translated, you can say that about 7,000 neonatal deaths occur per day. And of these 7,000 neonatal deaths that are occurring per day, a third of these children are dying in the first day of life. So the first day of life is very critical. And I will tie that to the fact that the best place for a child to be born is in a health facility or in hospital under the care of a skilled birth attendant. Because as you can see, the highest probability of death occurs in the first day of life. So the best place for a child to be born, because pregnancy can go anywhere. Anything can happen. When the child is born, there can be complications. And so you want to make sure that when those complications take place, the child is already in a place where they can receive specialized and care by qualified health workers. So take home message, the best place for a child to be born is in the hospital, because the risk of death is highest on the first day of life up to the first week of life. When we look at South Sudan, I've told you the global neonatal mortality rate is 18 deaths per 1,000 live births. We talk about live births because we're looking at all the children who are born alive, all right? Yeah, so of all the children who are born alive, how many then go to die? Now, globally, it's 18 deaths per 1,000 live births. In South Sudan, it's 40 deaths per 1,000 live births. So you can see that's much higher than the global rate. Then when we look at what is happening to our neighbors, Kenya, the neonatal mortality rate in Kenya is 20 per 1,000 live births. The neonatal mortality rate in Uganda is 20 per 1,000 live births. So it's basically double. And Dr. Idioro had also told us about the maternal mortality rate, and she did mention that it's actually double. So we are not doing too well when it comes to neonatal mortality rate. And in terms of how these figures are actually arrived at, mostly we get this data from birth registers. So if you find that maybe the birth of the baby has not been registered, or the baby has not been born in hospital, or, it may not be possible to get this data. So the figures for South Sudan could actually be higher than what we are looking at. Thanks.
Thank you so much, Dr. Grace. I don't know whether you guys can hear me now. Can you hear me?
Yes.
Thank you. I think I had to change a number of my gadgets. Now I'm on another phone, but thank you so much for taking over there. And I would like to emphasize on what Dr. Grace has talked about. The safest place for a child to be born or a newborn to be born is actually the hospital, because there, at least, if any complications arise, then there are skilled health professionals who are able to now take over and make the right decisions to save that baby. So we'll go straight ahead back to Dr. Idoro. Unfortunately, Dr. Idoro, you will be the one talking to us mostly about mothers. Today we have an overload of pediatricians and child health enthusiasts, but today you will be our mother, basically. So we'll go straight to the next question. Could you please just give us a brief overview of some of the most common causes of maternal mortality? And also, if you could mention and define these conditions and what the prevention and treatment is for them. Thank you.
Don't worry, Anne. Are we okay? I'm hearing an echo. Okay. And don't worry,
Yes,
they are all my students, so there is no problem. I can still lead them here.
Okay,
as you have all heard, we are leading in everything, which is bad. We are leading in everything that is bad. So I don't know how this one is going to be fixed, but let us keep on with the discussion. Some of the common cause of maternal mortality actually include bleeding, which is the #1 killer, and infection. Our place is just full of malaria and typhoid. Everyone walking on the street, you ask and he will just say you are on treatment for malaria and typhoid. So you can just see, and people start looking at malaria as a simple thing, which is not actually. And again, we have issue of high blood pressure in pregnancy. That is called preeclampsia. Also, this one comes #3. And complications from delivery, like obstructed labor, and then unsafe abortion. Now, all these things, if women come to antenatal clinic, we will be able to actually reduce the number of most of the complications. But when do our women come to clinic? Most of them said, I will go to the clinic when kanana bika saba shahar, yana bijara ino diktor besa shan bamulula ana sura, which is actually wrong. We encourage women the first day. Nowadays, you can just go to a chemist and take the pregnancy test strip. And most of them, they do the pregnancy test at home and they know they are pregnant. So the moment you notice you are pregnant, just see a doctor for once. At least the doctor will be able to guide you and tell you what to expect. Even if the doctor tells you come after 8 weeks, that is 2 months, still the doctor has already known how the pregnancy will go from your history, because the doctor will be able to take the full history and know your other pregnancies, if there were any complications before, and we can even give you this 8 weeks, and you come after 8 weeks. But people think that is the mentality. I will just say the mentality of us Africans. They will think the doctors just need our money, the ones with the money. They will think the doctors need our money. But the ones without money, it is actually the illiteracy that is killing them, because they don't know the importance of antenatal clinic. But in antenatal clinic, so many things happen. Like people will ask me, they come for antenatal clinic and I take the history. We have done the first trimester scan and she comes still at 13 weeks. And I'll just do my clinical examination and I tell them that is it. And they are like, Doctor, do you mean you have checked me? Is there anything wrong? What have you even done? Then I will start explaining to them. I have checked, I have felt the pregnancy, it is here at 14 weeks. I have done the fetal heart and I'm able to get it, so I feel there is no need for an ultrasound until the next visit. They said, with just your hand. I said, because we were trained to do that. So the ones who don't understand, they feel like you are actually doing nothing. So I think our women, they need to be done awareness, to know that antenatal clinic is very important. But I don't know if this one will work in Juba still, because it's still you come and you find the midwives are the ones running all antenatal clinic. There is no doctor in that antenatal clinic, and the midwives are overwhelmed with the mothers who are there. So I don't know how we will, but we'll still have to encourage them to go and check, because I know our midwives in Juba Teaching Hospital and in Malakia, they are well skilled. And most of my skills I got actually from them when I was a student. And postnatal clinic, you want me to talk on postnatal? Postnatal clinic is actually important. Like we said, maternal mortality is actually runs from the day you get pregnant until 6 weeks after delivery. So postnatal clinic is actually important because you can develop secondary postpartum hemorrhage. That is still within the 40 days. You can develop still the high blood pressure. That is still within the 40 days. So they are all important. If you are told after delivery, you come to the hospital, you come. But people think, why am I coming? I'm feeling well. Until I remember there was a time in Juba, and a young girl of 17 years who came back to the clinic because she was not able to see after delivery. She was not able to see, then the relatives brought her back to the hospital. And that was actually some complications of a high blood pressure, which is related to the pregnancy. But they will never come to the hospital as long as they don't feel anything. So this is our biggest problem. On predisposing conditions or risk factors of maternal mortality, and how do we lead and mitigate? I think I've really stressed on socioeconomic factors. This is actually number one killer of our women. Lack of education, parity, previous obstetric history. You even don't know the previous obstetric history. Somebody just comes like after delivery. I remember in Juba somebody coming after 2 days and telling me that she delivered 2 days ago and the placenta didn't come out. I was so mad. And the husband, you know, our men in Juba, they know everything. Even the one the doctors know, they are the ones who know best. So he wanted to teach me, and I told him, you either have to go out or I deal with your wife. The whole place was smelling because she was already having pepeural sepsis, and that sepsis could have even killed her. But now the man is there. She has delivered how many babies at home? So you think you want to tell me? I said, yes. Even if she delivered 10 at home, I still have to tell you that was wrong. And that is the reason why you have come to me today. So these are some of the things. Infection. We don't know that if I deliver at home, the place is not sterile, it's not like there is basically no hygiene in where I deliver. So I'm at risk of getting sepsis. And people will say, aye, she delivered very well, and we don't know what happened. She just had fever and she died. And when I'm being told such stories, and I know it is just sepsis that killed the mother, and they're like, no, and our people are still superstitious again. They'll say because she delivered, that one did this, the other one did that. These are all nonsense. People have to know that mothers are to be followed in clinics during pregnancy and after delivery. And there is a study which was done by one of us, Dr. Justin Tongun, which actually showed that most of the mothers deliver at home. So they just go and they think it is just a very easy thing, and they just deliver at home. Now they are the lucky ones. Because, you know, pregnancy is not all the same. It can go well, it can go wrong. And the ones that go wrong are the ones that come up. And you end up leaving small kids. not knowing who to take care of them, it is actually wrong. And we want to encourage everyone, the hospital delivery, whatever the situation, it's actually the best. And from his study, it is like from 800 women. I'm getting an echo. The rest, you can mute yourselves. There is too much
Dr.
echo.
Lucy, could you please mute yourself? Dr. Lucy?
Oh.
Yeah. So in his study, only 204 women from 800, only 204 had a delivery by a skilled birth attendant. So you can imagine, it is just people are just taking risks. And some people are so proud when they tell you that, me, I just delivered at home. Why should I go to the hospital? And they don't know that that one might be their chance. So I will just encourage every woman to just seek a skilled birth attendant and hospital delivery. In hospital, so many things happen. I remember when I was an intern, a new intern, every time I come home, I tell a story, what happened in the maternity. Then after some time, my cousin told me, do you mean that all the women who deliver in village, they survive by chance? And I told her, yes, actually they survive by chance. So me, I always have that, I always blame like if I had of maternal mortality and I'm being told it's so and so, and I'm like, I start weighing, why shouldn't she have gone to a better place? She's somebody who works, she's somebody with the money. You seek for yourself a better health service with whatever you have. I know poverty is a problem, but if you are able to afford, please just afford the facility of your choice and what you are able to afford. If it means even traveling to the US to go and deliver, you have the money, just go for it. It's better for you to be safe than people now crying later that this one has gone too soon, which is something which can actually be avoided. Now, I think I mentioned something about parity. Our women in South Sudan feel like they just have to give birth. As long as I still have the periods, I have to give birth. No, that is wrong. People have to know the number of children they need. I think, and you guys have to also prepare. One day we talk on family planning. I remember I made my choice from when I was dating, that this is the number of kids I need. You know, I just need like people to have their rights and know their choices. This is the number of children I need. If you want to deliver them every year, I don't blame you, because I know you have a plan for your future. You will finish them in 5 years, you settle and you go and work and do your things. But not that I'm just here to deliver. Like in Juba, a lady came, a young girl of 20-something years. Then I asked her, she was pregnant. When was your last period? She said, Dictor, ana maarufu. Min jozana, ana mainu doratai. Imagine such kind of things. And others coming, you ask them, when was the last period? And they look at the husbands. So actually, the husband owns them. The husband owns the woman plus her physiology and everything. Even the ones who decide to come for family planning, is the husband coming. Dictor, which one is the best? No, your husbands don't need even to know when your periods are coming. Your husband even don't have the rights to know what family planning to choose. It is you. It is the family planning is working for yourself. So, and the number of children is yours. You are the one taking care of them. So you have to decide, because otherwise you will die in the process of giving birth to many children because you want to prove something. There is nothing for you to prove, please.
Okay, thank you so much, Dr.
Okay.
Idoro. I think you have talked about a number of things. From the first point, you talked about the importance of antenatal care, and I think what you were saying is that it's important to actually attend clinics because that's where high-risk pregnancies are identified. You've also talked about some of the causes of mortality, including high blood pressure, infections, and this can happen before or even after delivery. And you have emphasized what Dr. Grace had said before about the importance of delivering in a facility. Why? Because, as you said before, most of the women who deliver out there and don't get complications have actually escaped narrowly. The importance of delivering in the facility, in the health facility, is so that these complications can be identified early, and these women are actually treated as they should before any complications occur, either to them or the children. Thank you so much for that overview, Dr. Idioro. Next, we will quickly go to Dr. Lucy, and I'd like to encourage the panelists to try and limit the answers to the questions to about 3 minutes. So, Dr. Lucy, if you could please unmute yourself. Before we go to Dr. Alice, could you please give us some of the causes and the risk factors for child mortality in the region and worldwide and South Sudan? Just give us a comparison of what the risk factors and the causes are, and then we can go to Dr. Alice, who will speak to us a little bit about the child health department that has recently been established. Thank you.
Okay, thank you so much. I will start by the leading cause of mortality in under 5 children in South Sudan, of which we have pneumonia. Pneumonia accounts for about 20% of under 5 mortality, and it's one of the most preventable causes of death, of which we will be able to prevent it if we do well on it. And then the second thing we have is diarrheal disease. And then also diarrhea is a preventable disease if we work well on it, put good sanitation and hygiene, so we can reduce the risk. And then the third is we have malaria, and then malaria followed by malnutrition. And then, of course, we have measles. Nowadays, we have a lot of outbreak of measles, and now it becomes one of our causes of mortality in the country. And not forgetting the neonatal causes, which covers about 29% of mortality in the country. And compared to the region, is still pneumonia, diarrhea, and malnutrition are still the leading cause of mortality. But in South Sudan, they are more higher than the regional sub-Saharan Africa or the region, or even in the neighboring countries of the East Africa countries. And also it's more higher than the global or worldwide. The major risk factors for under 5 mortality in the country, we still have lack of drinking safe water, and then sanitation and hygiene. Of course, most of these diseases, like if we talk of diarrhea, which is one of the cause of mortality, under 5 mortality can be prevented by when you are having good hygiene. And then not forgetting lack of basic health services. So these are all the challenges, or these are the risk factors that we may also have our leading cause of under 5 mortality. And then we also have low coverage of immunization. So the basic immunization coverage is also very low. And of course, we have the other preventable diseases that we may need to introduce, other vaccines that may lead to reduction in the mortality in under 5 age group. And of course, we're not forgetting suboptimal breastfeeding or infant young child feeding practices in the country is very low. In 2018, it's about 45%, but last year, 2019, we have come up to 74%, which is still low, of which we need to work hard on it. So basically, these are the most common risk factors for under 5 mortality in the country. Thank you.
Thank you so much, Dr. Lucy, for giving us that overview of some of the risk factors and the causes of under 5 mortality. I think what has come up from what you have told us is that there are quite a number of infectious diseases that have really influenced under 5 mortality, and some of these infectious diseases are actually vaccine preventable. And what we probably need to work on as a country is in terms of preventative care, ensuring that vaccine coverage in our country is adequate so that children don't necessarily unnecessarily get these infections. Now, we haven't heard from Dr. Alice Johan yet. Dr. Alice, can you hear me?
Yes, I can hear you.
Great. So, Dr. Alice, I think you're in a very good position to tell us a little bit about some of the things you are doing in the Ministry of Health, especially as a Director of Child Health. And we know that the department has just newly been created, and we would like to understand what led to this, like what inspired the creation of the Department of Child Health in the Ministry of Health, and why wasn't it there before? And what is the role of the Child Health Department? What role are you playing, especially in view of the causes that and the risk factors that Dr. Lucy has just given us? Thank you.
Yeah, thank you. Thank you for having me. The Child Health Department is newly developed for like 2 years now. And there was an age seen by the minister because the number of mortality from pneumonia, it was high during 2 years ago. And then Save the Children were actually the one who's asked Minister of Health that they need a focal point for pneumonia. So the minister thought that instead of having focal point for pneumonia, why don't we have a child health department? And actually that was the background for initiation of the office. And the child health department, because child health is supposed to be the bigger picture, the bigger department and the bigger directorate. We have nutrition department, we have immunization department, and also we have the directorate for primary health care. And if we compare to other ministries of health in neighboring countries, they are all under child health. Child health is the bigger picture. But now we're just starting the way behind. And actually, what child health is doing now, it's more of case management. Because nutrition department is doing the part of nutrition, immunization is covering immunization. And then now case management is not being followed. And it's actually in terms of having guidelines regarding child health and then having a strategy for child health. All this, we don't have it. So now for these 2 years, since the formation of the department, we are struggling to have a child health survival strategy. And actually this strategy is more of integration. It's covered immunization, it covers nutrition, even maternal and newborn health is part of this intervention for child health. And this is now the main thing we are doing. And the other thing is in the case management. So case management is formation of guidelines. And actually for child health, especially if we take, for example, like IMNCI. IMNCI, we have an outdated guideline. It's been there since 2009. And we're using the outdated one. And actually, it's a very big contribution to the child mortality as we look at those figures. And what we are doing now is we've already improved, we've already updated our IMNCI guideline, and we've already started the training. Actually, we're just moving all over the states. We are training health workers, nurses, doctors, and the low cadres, so that at least they know the guidelines in treating children. And IMCI is mostly cover those causes. If we look into the causes of child mortality, we have malaria, we have fever, then we have malnutrition, pneumonia. Everything is covered in IMCI, and it's a simple guideline. Everyone can follow that guideline, and this is one of I can say what we're achieving so far in that department. And of course, there is a lot to be done, but it's still we are still at the beginning. So we are looking forward to develop that strategy. Yes, thank you.
So for those of you who probably did not get what IMNCI means, it means Integrated Management of Childhood Illnesses. And as Dr. Alice Johan has said, it covers some of the more common causes of what we call morbidity in terms of illness in children and mortality. And I think what I have found interesting, Dr. Alice, is how you've talked about training and the training of health workers in this diseases that cause most of child mortality. And I'm glad that is something that the ministry is taking up. Apart from MNCI, could you please maybe give us other interventions that are probably in place to tackle some of the other issues that relate to child mortality or child health? Maybe just a brief overview before we go to Dr. Grace.
Okay, so other interventions we have actually most of the intervention it's integrated in other departments. Like in RMNCH, we are there. For newborn, we are part of it because newborn is taking like 45% of child mortality. So even the Office of Child Health is also having some part to work with a neonatal department or with reproductive, maternal, newborn and child health department. And also with nutrition, other thing that now the case management for severe acute malnutrition, especially it's also another big cause of mortality. And one of the things is the inpatient management. And most of the time, those patients who are admitted, they died within the first day. And what is child health as part of collaboration with WHO is that we've already updated that severe acute malnutrition inpatient treatment, and we are also part of training, which actually it's been there for like more than 2 years with Office of Dr. Lucy, who've been covering that inpatient management. And also another thing, because it's a bit difficult for this department now to just to be part of other departments, because now as I am, as a small department as I am, though it's a big department, to be part of bigger department which been there for over 10 years or for over more than 10 years, and then to come there and then tell them what actually needed to be done, it's a bit difficult. And actually this is what the department now is facing. So that's what we are doing now. Is more, we are focusing on case management. So it's more of looking into those hospitals, what's missing. Especially we have one referral big hospital, Al Sabah, and it's where we are focusing more and looking at what's missing there in terms of human resource, in terms of supplies, medicine. Most of the time we go there and then we see what's missing and then what Ministry of Health can help in terms of upgrading or in terms of improving quality of care in that hospital. And of course, we can't forget about the states. But the problem that access to those areas, it is still having problem. And what the department needs more is to have the guideline and then to have the strategy, the child survival strategy. And that strategy is a big document that normally helps you. If you want to go to other departments, you need to have that strategy. And what's the intervention in that strategy? And then you focus, and then you go to that department and tell them that child health is looking at these interventions, what is being done and what's needed to be done. Thank you.
Thank you so much, Dr. Alice. I think you've just given us an overview. It's a bit, it's actually encouraging that it's something that is in the works and that the department is actually looking into developing a plan that can then trickle down to the states and the counties and be implemented, and that the people at the Ministry of Health are actually aware that on the ground things are different, and the medications and the infrastructure that is needed to ensure that particular whether they're infections or certain cases are being able to be managed at the hospital level, even as high as the national level. And this is something that will take the ministry a bit of time to get in place, but the fact that you have already started that work towards the path of bringing change, that is very encouraging. So next we'll go to Dr. Grace. Dr. Grace, at some point I disappeared from the discussion, so I'm not sure whether you already mentioned some of the risk factors for neonatal mortality and what the causes are. And if you have, then if you could just go a little into some of the interventions that have worked worldwide in reducing the burden of neonatal mortality and have improved newborn survival. Thank you.
All right. I didn't talk about the causes of neonatal mortality, so I'm going to go straight into that and go into the interventions also. Before I proceed, I'd like to reiterate what Dr. Iduro said, that every pregnancy is different, and I would also like to say every baby is different. So whatever happened in the past pregnancy, whatever happened to the other baby, you cannot do the same for the next baby that you're having. Then also just a clarification on IMNCI, it stands for Integrated Management of Neonatal and Childhood Illnesses. The N was included to cater for neonates because previously we were dealing with IMCI, which is Integrated Management of Childhood Illnesses. And what we saw is that as the under 5 mortality rate was going down, the neonatal mortality rate was going up. Why? Because different strategies are required for the neonates. You do the same strategies for the neonates as you are using for the older children. So that's why now we are having IMNs here. I'm glad the Department of Child Health is tackling that. So the causes of neonatal mortality globally are similar to that of South Sudan. We have preterm birth. A preterm birth is birth of a baby before 37 weeks, and that becomes associated with problems of what we call a small baby. And basically the small baby would be a premature baby and a baby who is low birth weight. Low birth weight, meaning that the kgs are less than 2.5 kilograms. So that comes with a lot of problems, which I will talk about briefly. So preterm birth, then we have intrapartum or birth events. And these are mainly related to problems due to a difficult labor or a difficult delivery. And as Dr. Idiro has said, the best place for a baby to be born is in the hospital, because if the labor becomes prolonged or difficult, then doctors or midwives or nurses can intervene. But if no intervention is done early, then the baby is going to get tired, all right? And if the baby gets tired, that means they're going to have difficulty breathing. When they have difficulty breathing, by the time they're born, they will not cry properly, all right? Or by the time they're born, you'll see maybe the water is green, and that's what we call meconium. You know, when the baby is stressed inside, then they poop, and instead of the water that breaks to be clear, the water is then green. That also brings problems with breathing. And when you have problems with breathing, it means that oxygen does not go to the brain. When oxygen doesn't go to the brain, the effects of that will be felt much later. You'll get babies who cannot walk, not stand. And if you think about it, you know, if you can prevent that, because caring for a baby who cannot walk, who cannot develop like other babies, is more expensive than actually delivering your baby in hospital, and those problems can be taken care of. So you have preterm birth, you have intrapartum events, which cause difficulties in breathing. Then you have infections, all right? And it's been mentioned earlier, infections, when you deliver in hospital, can be taken care of, because in hospital we ensure that we use clean hands, clean surfaces, and clean delivery equipment, and that prevents infections. There's also the other aspect of infections after delivery, and that has to do with how you take care of the cord. And if you deliver in hospital, you will be advised on how to take care of the umbilical cord. Then number 4 is congenital birth defects. Some congenital birth defects are obvious, some are not obvious, especially congenital birth defects that have to do with the heart. Those will cause problems in breathing. And if you give birth to the child not in hospital and they start having this problem, they may look normal, but inside they're not normal. If they start having these problems with difficulty in breathing, you don't have oxygen at home. So how are you going to help the baby? Okay. So as I've mentioned about those 4 causes, the same is true for South Sudan. And in addition, in South Sudan, we have problems with diarrhea and we have pneumonia that are additional. So the 4 important things that a baby needs when they get born are: 1, they need to breathe properly, they need to be kept warm, they need to be fed, and they need to be protected. So I've talked about the breathing, because if they have difficulty in breathing, if they're in hospital, they're going to get resuscitation where they'll get oxygen, and that will help them to breathe properly. Warmth and feeding. Warmth and feeding go hand in hand, all right? And here I'll talk about 2 killers of children, and that is hypothermia and hypoglycemia. Hypothermia is when you have low body temperatures. Hypoglycemia is when you have low blood sugars. Okay, so I mentioned the preterm births, that is the small babies. The small babies are at high risk for these 2 problems. Number 1, because they have poor heat regulating mechanisms, and that puts them at risk of getting low temperatures. And number 2, they have low glucose stores, so that puts them at risk for hypoglycemia. How do you prevent that? Is by keeping the babies warm, is by feeding the babies, all right? And so feeding the babies ensures that they get glucose, which they can use to keep warm. The other thing is protection of the babies. Babies need to be protected against infection. Why? Because they have reduced amount of immune cells and they have poor immune mechanisms. I'm going to go straight into interventions. Is that okay?
That's fine, Grace. Please go ahead.
Yes. All right. So as I've talked about the causes, as I've talked about the needs of the babies at the time of birth and how these are related to the causes, I'm going to go talk about some of the interventions. And I'm going to focus these interventions on mainly the three aspects that I think are very important: prevention from hypothermia, prevention from hypoglycemia, and prevention from infection. Okay, when we talk about hypothermia is a temperature, is a body temperature that is less than 36.5. And hypothermia can cause death because because the baby is not warm, the baby is cold, then glucose is going to be channeled towards keeping the baby warm, and there'll be no glucose that is being used by other organs, like, for example, the heart and the lungs. And so you'll get problems and difficulties in breathing, and that's how the baby will die because of what? Hypoglycemia. Hypothermia. How do we prevent hypothermia? There are 10 steps for prevention of hypothermia, and that is called the warm chain. So what is important is warm delivery. The place where the baby is being born has to be warm. And in hospitals, we ensure that that happens. The next step is immediate drying. Immediately a baby has been born, the baby has to be wiped and dried properly to ensure that they are kept warm. Number 3 is skin to skin contact. So if you've just delivered your baby, the baby should be placed on your chest so that your heat can transfer to the heat of the baby, and that helps in keeping the baby warm. Number 4, breastfeeding. Breastfeeding has to be initiated within 1 hour at birth. So this business of separating the mother from the baby, it interferes with breastfeeding, which prevents hypoglycemia, which prevents hypothermia. Number 4 is delaying bathing. Okay, bathing has to be delayed for like 24 hours to ensure just that the baby is kept warm. And if you're going to bathe the baby, make sure that the place where you're bathing the baby is warm. The room has to be warm. Number 6, warm clothing, warm bedding, okay, warm resuscitation, warm transportation. Whatever you do, the baby has to be warm. And you know, the problem is in South Sudan, we think because the temperature is so high, the baby cannot suffer from these problems. The baby will be at risk of this, especially at night. And so you have to keep them warm with at least 2 more layers than what the adult is wearing. And make sure you cover the head and cover the feet. I've talked about hypoglycemia. I've talked about hypothermia. So about infection, how do we prevent infection? We talked about clean hands, clean surfaces, clean delivery. And also another thing that prevents the infection that occurs for neonates is ensuring that you receive the tetanus immunization, the tetanus vaccines during the pregnancy. And then another important thing that will prevent babies from infection is just try to keep I know in South Sudan, when a baby is born, everybody wants to go there, but I would really encourage that it is better that the mother and the baby are kept alone, at least for the first 2 weeks, because the baby is at risk of getting infection. Everyone wants to hold the baby, everyone wants to touch the baby. Before you hold or touch a newborn baby, please wash your hands. Okay, please wash your hands. All right. Let the mother spend time with the baby. Let there be minimal contact. You can see the baby after the 2 weeks, because by then their immune systems will be better and they'll be able to fight off infections. Then another very important one is the care of the cord. And this is where I've seen a lot of problems in South Sudan. You will see a baby has been born very well, then they come to you in the clinic and the temperatures are spiking to the roof. Why? Because the baby has an infection. You open up the baby and you will see a lot of green stuff on the cord. I've seen that firsthand. People like to apply all sorts of things on the umbilical cord. I'd advise against that. The only thing that you can apply that is recommended on the umbilical cord, if you feel that you have to apply something, is 4% chlorhexidine, which should be given from the hospital. And this is mainly for babies who are not born in a clean environment. Say, for example, they're born at home. But babies who are born in hospital and the delivery was clean, is just leave the cord like that. But if you must put something, put 4% chlorhexidine The other thing that prevents babies from infection is Tetracycline Eye Ointment, which prevents, whereby the eyes are clean and then the Tetracycline Eye Ointment is applied, and that prevents infections that can cause blindness. So it's important to know that, because you may find that in many places, maybe that may not be given. And finally, I'll repeat, breastfeeding is very important, exclusive breastfeeding, especially for the first 6 months, because the milk contains substances that will prevent the baby from getting infections. So that is about prevention of infections. Yeah. I have a few more things I want to say, so if you give me some time later, maybe I can finish up on that.
Great. We will give you a little time later. Thank you so much, especially for the correction on the addition of the neonatal care into the IMNCI. I'd like to say that the interventions that you've mentioned, I like the way you put them in steps, and the fact that some of these interventions are actually very simple but life-saving for children. And it's good that you mentioned them in this forum, so that people are aware, and they're also aware of the importance of actually having these babies born in the facility, so that all those steps are taken into account. Now, next, I'd like to go back to Dr. Idioro. Dr. Idioro, you may have mentioned this before, but I'd like you to just give us a few of the signs that mothers should watch out for in terms of what we refer to as danger signs in pregnancy and after delivery. And if you could also give us a brief overview of what we healthcare workers consider as the indications for Caesarean section, and what are some of the complications that might occur post-Caesarean section, and what is done about them. So danger signs to watch for during pregnancy and post-delivery, and also what the indications for Caesarean section and the possible complications are. Dr. Idioro.
Okay, thank you, Anne, for giving me the chance once again. During pregnancy, the danger signs, like in the first trimester, that is the first 3 months of pregnancy, we actually encourage people to look at, the women to look at if there is bleeding or severe abdominal pain, or if there is like pain during passing urine. And in Juba, or in South Sudan, we always encourage them, if there is any sign of malaria that they know commonly, they should just seek medical advice. They come to the facility instead of going to the chemist and buy any medication, because not all medications for malaria are indicated during pregnancy. And in the second trimester, again, bleeding comes. If there is drainage of the water, if you start seeing the water, because that is actually the risk of infection. And when we go to third trimester, again, we have that bleeding history. If you see any bleeding, and if you feel the baby is not moving well, and third one, again, if you are draining the water, these are all the things which should make a mother to come to health facility, so that we are able to do a scan, or just the clinical exams, and then do a scan and some investigations to check whether everything is okay. Like Grace is saying, we lose most of our babies during in the first day of delivery. That is actually because most of them, like if you stay long, more than 3 days, actually we say more than 24 hours. If you start draining the water, you have to seek medical advice, so that if after 34 weeks we are to deliver you immediately, if before, then we have to give chance for some steroids to be given. Otherwise, that baby will come out with severe sepsis, and even the mother will develop sepsis, which actually is a cause of mortality and morbidity to the mother, both mother and the baby. Again, since high blood pressure also comes in the third trimester, like usually after 20 weeks, we know during pregnancy there is that small headache, nagging headaches. That one is okay, but if you feel a lot of headache, that one you should seek medical advice, because again, it could be the high blood pressure that is being reflected as headache. Epigastric pain, if you're able to pick, which most of the time I know women ignore and say, no, this is Haragan. because of the pregnancy. Yeah, hurricane of pregnancy is there, but if it is severe, kindly just seek medical advice on that. Let's go to cesarean section. I think some few years back, when we were taught that if you see a short lady and who is pregnant, that is effect, and the shoe size, that is now an indication for cesarean section. But nowadays, after sometimes WHO has recommended every woman should be given a chance for normal delivery, and that brings us to the importance of delivering in health facility, because you will always be monitored, the labor will be monitored, and this regular examination will be able to detect whether the baby is coming or the baby is not coming. So, and you will be surprised that the short person that long time ago used to be done cesarean, nowadays they give even birth to 3.5 or 3.8 babies. So we recommend CS during labor. For first time cesarean section is always indicated during labor. And for people with cesarean who had a cesarean before, like if it is 1 CS, then we have to find from the history what happened, why did she go for CS. Then we know if it is a recurrent cause, like if it is said that it was cephalopelvic disproportion, that one definitely I will not give you a chance. But if it is said no, the cord prolapse or the baby was in distress, I will give you a chance with some conditions whereby I will have to know the weight of the baby, I'll have to weigh the presentation of the baby, and you have to make sure you come to the health facility in case you feel any labor pain. And again, I will encourage you just pray to your God that labor comes immediately after 37 weeks, and because you don't have to pass your date. The more you pass your date with one cesarean section scar, the bigger the baby becomes. So usually if you deliver between these 37 weeks and 40 weeks, you will get a good outcome, but we'll have to discuss along, and you have to know the risk of trying that scar and all that. And we have a 75% success for trial of VBAC in the hospital where I'm working. And after cesarean section comes with a lot of complications. That is why we always encourage, like we say, one cesarean, always cesarean. So if you can always prevent the first cesarean section, it is always good. But now I can't compromise care because I just want to prevent the first cesarean. No, it has to be with the appropriate care given. Because now cesarean section has the risk of bleeding. First of all, we are cutting, there is a risk of bleeding. And after cutting from the skin, you reach the uterus where we give the incision on the uterus. The bladder is near there, the intestines are there, so injuries to any can happen. And but when you work in a facility whereby there are surgeons, we call the appropriate people to come in and correct whatever defect is made during the surgery. Although they rarely happen, but they can happen. So everyone going for cesarean section should know about this and sign a consent that they know they are explained to about all the complications and the outcome of cesarean section. Yeah, now there is that point for midwives and traditional birth attendant. Midwives and traditional birth attendant, like Grace has just said, we had that IMCI. I'm still in the old school of IMCI, but now it is IMNCI. The traditional birth attendant, they are just taught like that IMCI thing. This is how, with experience, they do the digital exams and they actually pick whether the baby is coming in the right position, if the head is presented well, and they give the time. If they will really assess and know when to refer. They are actually being trained on when to refer, and timely referral usually gives us a good outcome. Because again, as obstetrician, if we don't manage the labor well, we give dose of grace a batch baby which they cannot even rescue. So actually, the traditional birth attendants and midwives are very crucial in the management of labor. So even if they have not gone to school, the traditional birth attendants have worked with many, and they are really able to pick when to refer a patient, and that is what is important for us. And our barriers mostly in South Sudan because of to maternal care. Like I've said earlier, the numbers are too many for the midwives. First of all, for those who go and attend, and others think like pregnancy is just a normal thing. I don't need to go, and others is because of the distance. It needs a transport. I have to go to that health facility, which is usually very far, and they are not able to make it to the facility. That is what brings us again to the 3 delays that lead to maternal mortality. And the 3 delays, I think I've spoken on everything. First of all, like we say, the rights. The first delay is from home, when you decide where to go, which facility are you going to. Like most women, they have been pregnant for 9 months, but when labor comes, they are caught by surprise. Where am I going? Which facility? They have not even decided in the first place which facility to go. Now they're deciding the facility. No, the husband has to come. He has to agree with that facility. And remember, this is time which is moving. Now the husband comes. No, the mother-in-law. Where is she? We want to go to the hospital. And the mother-in-law, no. I gave birth to nine kids all at home. Why should she be taken now? So with that discussion, it has already taken like almost 10 hours. By the time they agree that this lady has to be taken to the hospital, now the lady is already tired. There is, we don't know, the obstruction has already happened. The baby by itself is tired. Now they reach our weak health facility. In our health facility, now they reach there. Dr. Diora has just gone home. He is not there. She's called, me, I'm still breastfeeding my baby. I'm coming. So when I reach even there, where is Alice? Alice, please, we are having a baby. You come to receive. Alice is very far away. So the delays is all over from home, and for them to access the health facility. And in the health facility, we have our own delays. So this one actually contributes to maternal mortality. And that is how we have it more even in South Sudan. Thank you.
Maybe Lucy, you can continue.
Thank you, Dr. Idoro. Okay. I'm sorry. I think when it comes to some of these gadgets, you have to be very, very used to using them. But thank you so much, Dr. Idoro, for that explanation. And I think in a brief overview, you've talked about some of the danger signs, including bleeding, including the headaches, including reduced movements for the babies that the mothers have to watch out for. And I like the way you have talked about some of the indications for Caesarean section, and you have divided them into things that can recur and things that don't recur. And that is really important, especially for those of us who practice in the health profession, to be able to know that this is a direct indication for a Caesarean section and this is not. And I think the mothers should also be aware, as you have said, that once you have had the first Caesarean section, it's always important to deliver in a health facility, because trying that scar at home will be dangerous. So thank you so much for that, Dr. Idoro. So next, we will go to Dr. Lucy. I think we haven't heard from you for a bit now. If you could please unmute yourself. I think Dr. Alice has talked a bit about some of the policies that are being put in place for child mortality and neonatal mortality in general. So I think for you, you could just tell us, I'm sure the mothers on this forum and the audience that is watching is asking themselves, what is our role? We've talked about what us healthcare workers do, but what is the role of the caregiver? What role do they have to play to reduce the burden of child mortality? And what are some of the key household practices when it comes to child health care that can contribute to reducing the child mortality, especially in South Sudan? Thank you.
Okay, thank you. So before answering that question, I also wanted to elaborate a bit in one of the causes of the leading cause of malnutrition in the country, or causes of under 5 mortality in the country, which is malnutrition. And malnutrition attributed to about 30% of under 5 mortality is attributed to malnutrition. And malnutrition can be acute and chronic. So we are talking more of acute malnutrition rather than chronic malnutrition. So in acute malnutrition, we are having severe acute malnutrition, and then we also have moderate acute malnutrition. And in chronic malnutrition, we talk of stunting, which is a long-term malnutrition. So in severe acute malnutrition, so basically you are talking of malnutrition, severe acute malnutrition with medical complications. So 10% of those children with severe acute malnutrition develop medical complications, and that's when they get into the hospital or admitted and receive treatment, and it's one of the causes of the mortality. It forms about 20 to 30% of case fatality in health facilities. The prevalence of stunting in the country is at 30%, which is higher compared to the neighboring countries, to the region, and globally. And also the prevalence of wasting is at 23%, which is also higher compared to the region and globally. So those children with severe acute malnutrition, they are at risk of developing more infections. So the infections is because they have some other physiological changes that happen into their body, which we call as a reductive adaptation, of which the limited calorie that they have in the body is basically safe for critical functions in the body. So most of them develop infection, and they don't present like other children because of these under malnutrition issues. So sometimes they come to you without fever, and then you thought this child is not having infection. So basically, any child who comes to a facility with severe acute malnutrition, you presume that child is having infection, so you have to treat with antibiotics. So basically, this is, and some of the risk factors for malnutrition, we have food insecurity in the country, and food insecurity can be due to environmental disasters, like now we are having floods, and then economical crisis leading to food insecurity. And then number two, we also talk of the suboptimal breastfeeding or feeding practices in children. So these are all the some of the leading causes of malnutrition in children, and also we talk of hygiene and sanitation. So these are all risk factor for malnutrition. So coming to the question of what are the things that we may need some of the parents or mothers to do at home. So we have the interventions, we have the healthcare interventions, and then we also have healthcare workers interventions, and then we have some of the things that the mother can do at home in order to reduce the burden of under 5 mortality. So if we can start with healthcare interventions, so we have that maternal and newborn healthcare. So basically here we need to talk in the expansion of the antenatal services to the mother, and then we have the skilled birth attendants, and also we have the postnatal care to be in place at least. With this, we can reduce the malnutrition in under 5 children. And then number two is appropriate treatment of major childhood diseases, of which most of them are under the causes of mortality in under 5 children. So we talk of diarrhea, we talk of pneumonia, malnutrition, and then measles. So basically, we need to have a good idea on how we should treat these children by giving provision of ORS to those who are having diarrhea to prevent dehydration. And then also, this also can be done by the mothers at home. So we need to give a proper health education to the mother. So once a child develops diarrhea, what are the things that they can start doing at home? So one of them is they start giving ORS, is basically to prevent dehydration for these children. And then thirdly, we also need to talk of vaccination. So we need to improve our immunization or vaccination, and then we are also advocating for some other disease preventable disease, vaccine preventable disease, like we talk of pneumococcal conjugated vaccine, which will help us in reducing the pneumonia rate and mortality due to pneumonia. And then we also talk of rotavirus vaccine, which is not included in our expanded immunization program, in order to prevent or reduce mortality due to burial diseases. And then also we talk of good feeding practices and breastfeeding and nutrition practices. So basically, WHO and the National Guideline for MNYCN is recommended that early initiation of breastfeeding should be within the first hour of life, and then breastfeeding, exclusive breastfeeding should be continual for 6 months, and then continue breastfeeding with complementary feeding. So most of the time, if you are talking of malnutrition, malnutrition usually occurs between 6 and 23 months of life. And this is when the issue of complementary feeding comes in. So at this point also, we need or will advise our mothers also out there to focus on providing the complementary feeds to the children. And then also breastfeeding has to be continued on top of the complementary feeding. And breastfeeding has a lot of benefit, especially in the first 6 months of life. It prevents infection, and it also acts as like an immunity to the system. And it's important to both the mother and the child. It prevents malnutrition also because it has a lot of everything. And for breast milk, of course, sometimes you can see mothers, most of the mothers, if I can say like 80% of the mothers who come to us in the clinic, they said they are not exclusively breastfeeding their children. If you ask why, they tell you there is not enough milk. So most of the time we keep on advising them and telling them the importance of breastfeeding, and then there is nothing called there is no breast milk. So if you breastfeed your child, this will stimulate the brain and increase production of the breast. The mature breast, most of the time, we have the pour milk, and then we have the hand milk. And then some of them also give water to the children. They say the breast milk doesn't have enough water. That's why they need to give water from outside, at least to reduce thirsty. But from here or from this forum of ours, I'm telling our mothers out there, breast milk has enough water, especially the full milk has enough water to relieve the thirsty from the children. So let's continue with breastfeeding our children, and exclusively for the first 6 months of life, and then continue breastfeeding for 2 years and with complementary feeding. And also we need to talk about good hygiene and sanitation, because this is also one of the leading cause of mortality in under 5, because if you are having this poor hygiene, poor sanitation, no safe drinking water, all this contributed to increase the real diseases to our children. So basically, we need to emphasize on that. And then to the mothers also, we need to provide them with a good health education. So health education in one, we need to also advise them in or educate them in what are the danger signs. So at least once a child develops a danger signs, they will say, oh, this is now danger, let's rush to the hospital. So some of the danger signs we said is when the child is having high fever, and then you need to control the fever at home by giving paracetamol, and then rush to the hospital to check what could be the cause of that fever. And then number two, if the child is having diarrhea, so sometimes giving them signs of dehydration is difficult, but once the child is having diarrhea, advise the mothers to get ORS at least at home to start to prevent dehydration. And then, of course, other danger signs we also need to give them, so that at least once they are coming to the hospital, they have already done some of these basic things at home, and then preaching to us, we are only going to check what would be the cause of that. And then also we need to encourage them in breastfeeding. As I've said, breastfeeding is very, very important, and then it reduces malnutrition, it reduces infection, and all those things. So we need to encourage them in exclusive breastfeeding and continuous breastfeeding from 6 months to 23 months or 2 years of age with additional or complementary feeding. So this is what I can say. Thank you.
Thank you so much, Dr. Lucy, especially for going into malnutrition and some of the effects and the way it can become a vicious cycle where you're malnourished and you're unable to fight infections, and then you get infections, and that leads to issues with your development and eventually affects your productivity even as an adult, or even may lead to death. And the fact that food security is very important when we think about malnutrition, and even the water provision of water, sanitation, and hygiene when we talk about diarrheal diseases. And for going into the breastfeeding and the practices that would help the children to actually maintain good nutrition. And that is a role that us as mothers would have to play in creating an environment that is hygienic to ensure that our children don't get these diarrheal diseases. And thank you for also emphasizing the importance of vaccination and actually going for the vaccines and getting the children vaccinated so that they don't get infected with diseases that are vaccine preventable. And this will lead to a further reduction of mortality. So the next question goes to Dr. Alice. You were able to tell us about some of the policies and interventions that we have in place to reduce child and neonatal mortality. I think you also mentioned some training that is ongoing for IMNCI and other aspects of prevention of child mortality. And we know that human resources is a big issue when it comes to healthcare, especially in our country. And if you could please expound on what the role of training is and what are some of those specific things that the health workers are trained on, and how exactly those trainings are going, especially in South Sudan. Whether do you have people who actually show up for the training? How many people have you trained? And are these people able to actually go and work in those remote areas that don't really have access to healthcare to the standard that would be able to contribute towards reduction of child and neonatal mortality?
Yeah, thank you for the question. So when we talk about human resource for health, so especially for child health, in order to have enough human resource, you have to look at the level of care. So most of the points of care, starting from community and then coming to the primary health centers and then primary health care units, and then come to the hospital. And all these levels needs health workers, needs a human resource in those levels. So if we're starting at the level of community, so Ministry of Health are now having what we call the Boomer Health Initiative. And the Boomer Health Initiative, actually, it's reaching those who are at the community level. There is a Boomer Health team who normally goes house to house and then providing care to them. And those Boomer Health team needs to be trained on what exactly they need to be asked, what they ask mothers in terms of child, what's needed in terms of questions. As the child sick, identifies some danger signs, and then sometimes provide good information and good referral, send them to a good referral system. And also, if they can treat, they can start giving the first dose and then refer them. And the Puma Health team are now all over the states, and those teams are being trained. Up to now, there is training. And actually, people are coming up. For the Boomer Health team, you don't need an educated. It's more of, we don't need a high level health workers, like someone who have a bigger degree, someone who can able to read and able to communicate. He's been involved. And for the Boomer Health training, most of the health workers within the community and even the community members are part of it. And there's a good number of they normally come up, and most of the time, Ministry of Health is difficult for them to conduct all these trainings, and that's why we rely most on partners. We rely on WHO, we rely on UNICEF, UNFPA, Health Pool Funds, and all of them. They are the one now conducting those trainings. And what Ministry of Health is doing is that we are providing the facilitators for that training. We're just giving them the facilitators, giving them the materials, and then they are the one to print, and then they are the one to cover all the finance expenses of those training. So if we come to the level of primary health centers, where it's been under, it's just to be covered by a clinical officer. There's a clinical officer there, and then there is a nurses, midwife. Then the services there, it's more of the services, there is vaccination in terms of immunization, there is an outpatient, pharmacy, laboratory. And all these levels, they need a health worker to be there. And most of the time, they need to be upgraded and they need to be trained in what's the new guidelines. And in terms of PHCCs, most of the time, I'm not only talking about Juba, but it's all of Sudan at all, South Sudan at all. So we're having problem reaching those PHCCs. And there is problem even bringing those health workers to come to training, because most of the PHCCs, you only have one clinical officer, one nurse or two nurses. So if you bring them to training, some of the times you can cover all of them. And it's still the quality and the standard of care most of the time is low. So if we come to the national level in terms of hospitals, still we're having problems of training those health workers, because at hospital level, we have that health worker who thinks that, because most of them are the higher cadres, and most of them think that we already been taught about it in our high school. We've been taught about it when I was in my institution. I've been taught about it. So most of them, they come up from national level. It's a bit challenging. But what Ministry of Health now is doing is that we are bringing them one at a time. So if we're bringing half, and then next we're going to bring half. So in terms of training, the Boomer Health team, there is a training for Boomer Health team. There's a training for IMNCI. There is also training in nutrition regarding maternal, newborn, maternal, infant, and young child feeding. Also, there is training in nutrition. And there is other training regarding severe acute malnutrition, inpatient management. So in terms of training, most of them, yes, we can get them. But the problem is, to conduct a training, you need a partner who's covering those areas. Because South Sudan now is covering, it's been divided into zones. And each zone, there is a partner who's in charge of that zone. Unless a partner comes to Ministry of Health and say that I want to conduct this training, sometimes it's difficult for Ministry of Health to go there and do that training because it needs finance. So the partner will come and say that they want training. Ministry of Health will provide facilitators, will provide materials, and then it's up to the partner on ground now is to conduct that training. And at the end of the day, after the training, there is a supervision. We are going back for supportive supervision to monitor what's happened. Is there change in terms of management? Is there change in terms of quality of care or not? So these are in terms of training, in terms of what we are doing now within my department. Thank you.
Okay, thank you, Dr. Alice. I'm encouraged with especially that program you're talking about community members who are not necessarily health professionals, who are taught some basic skills in terms of identifying danger signs and being able to disseminate that information to people on the ground. The fact that we have to work with partners, I think in the transition period, that is probably acceptable, but I hope that the Ministry of Health is putting in place ways to finance their own training of our human resources. I actually appreciate the fact that the Ministry of Health actually does supportive supervision after the trainings and is able to look at the impact in terms of before the training and after, in terms of whether care has improved or not, or whether there are any effects on the number of deaths and the number of illnesses that are experienced in that particular setting where the individual works, the individuals that was trained. And I think that's important, the availability of data to be able to show us that this intervention is actually effective is a very good thing that I think the ministry should continue with. Now, I think we'll go back to Dr. Grace. You are to talk further about some interventions before I cut you short, and some of our members are also asking a few questions. One of them is asking what happens when a woman dies after giving birth? What kind of care will be given to this child? And also someone would like to know, how about things like neonatal jaundice? What are some of the causes for that, and how is it managed? I think from some of these questions, we sort of might have failed as medical professionals in giving information, especially when some of these women come to deliver in the facility, or be seen by our healthcare workers. So if you could please continue with the interventions that you are going to mention, and maybe also talk about what happens to a newborn whose mother has passed away. How are they taken care of?
Okay, I see a number of questions, and I can also see that time is running out.
Yeah, in view of the time, I think we should limit the answering of the questions. So I'll give you about 5 minutes to just wrap up that discussion, and then after that we can go around and talk about some of the conclusions and recommendations for each panelist. Thank you.
Yes. Yeah. So in view of the time, I think I will just answer the questions on the question feed and just try and complete some of the questions. I may be able to answer with some of the interventions that I will talk about. So I want to proceed to talk about danger signs that every mother or every caregiver should look out for in a newborn. Number one, if the baby is not feeding well, that is a danger sign. Number two, if the baby is having convulsions, and by convulsions, you'll either see they're having jerking movements of the hands or the feet, or maybe the eyes are rolling, or maybe they're just having like continuous movement of a certain part that is involuntary. That is a danger sign. If the baby is having fast breathing, all right, that's a danger sign. If the baby is having severe chest wall indrawing, by chest wall indrawing, because sometimes mothers will complain that, oh, the baby, he's not breathing okay. So I ask, all right, how does the chest look like? And chest indrawing is when the lower part, it's going deep inside, all right? And if you see that, that's a danger sign. Another danger sign, if the baby does not have any spontaneous movements. Another danger sign is if the body is cold or the body is too hot. Another one, jaundice, which I'm sure someone has mentioned. Now, for jaundice, what is important to note about jaundice is if jaundice is yellowness of the eye, of the mucous membranes of the eyes, or the, anywhere that normally does not look yellow starts to look yellow, all right? And that is, yeah, so if you notice any yellowness of the skin, of the eyes, of the mucous membranes, within the first 24 hours of birth, that's a danger sign. Take that child to be evaluated further. If you see yellowness in the baby, and you can see it on the palms and the soles of the feet, that is also another danger sign. It means that the levels of bilirubin, which is a product of metabolism, are very high, and that is something that is dangerous, because if it is so high, then it can go to the brain and bring problems later on. So those are the danger signs that I want all mothers to take note of. And I'll post something on the group which can be used as a reference for danger signs to look out for in newborn. Now, for the interventions, I'm just going to break it down to different stages and what caregivers, health workers can do. So at birth, what will ensure that we are able to save our newborns so that they can survive and they can thrive and they can grow up to be healthy adults? I cannot reiterate it any further, skilled birth attendants. And this is important because the skilled birth attendant rate in South Sudan is what? 19%. So we really have a lot of work that we need to do. Dr. Ijoro talked about traditional birth attendants. I'll say yes, that's fine, but also note that these traditional birth attendants should not be giving birth should not be delivering these babies in their homes, all right? Because that's another thing that people also like to do. Because even if they deliver in their home, they don't have some of this equipment that is needed in the hospital. Another thing also, the traditional birth attendants are supposed to work under the guidance of a midwife or a midwife assistant. They're not supposed to be working independently. I know that in South Sudan, we have a shortage of healthcare workers, and we like to incorporate them to help in deliveries. But actually, I don't think they fall under the definition of skilled birth attendants. But the reality is that they're part of the people who are doing deliveries, but they need to do that under the supervision or guidance of either a midwife assistant or a midwife. So skilled birth attendants. Number 2, another intervention at birth is newborn resuscitation. So for babies who are not breathing very well, health workers are trained to do newborn resuscitation, and that involves either giving oxygen or chest compressions as required, or just removing whatever secretions are there to ensure that breathing is okay. Number 3, and newborn examination is an important intervention, because when a baby is examined, then other things that could cause future problems can be identified. And some of those things that can be identified are congenital malformations. There's a question that came up about congenital birth defects. As I said, some can be seen obviously, some cannot be seen obviously. And sometimes when you find that a baby has just died suddenly, it could be because there was a congenital problem that was not identified. But there's another congenital malformation that can be prevented, and that is neural tube defects, and that can be prevented by giving folic acid. So folic acid taken during pregnancy prevents neural tube defects. Then the other important thing is the mother should stay in the hospital for a minimum of 24 hours to ensure that if there's any other complication that happens, then it can be taken care of. At the point of discharge, they should follow up with immunization, and they should go for postnatal visits. All right. The first one should be before discharge, the second one on the 3rd day of life, the third one within 2 weeks, and the fourth one at 6 weeks. Essential care that I've talked about, keeping the baby warm, taking care of the cord, breastfeeding, vitamin K is another important one, which I have seen that is not so commonly practiced in South Sudan. All right. And you'll find that even vitamin K itself is not even available. So I urge caregivers, when you know what you deserve, you will ask for it. So vitamin K is an essential thing. Ask for it. When you ask, when you create a demand, the market responds to it. So if you ask for vitamin K, it prevents bleeding in the baby. It will be available in the market. Then the other thing is cleaning of the eyes and applying Tetracycline Eye Ointment. For mothers who are HIV positive, please remember, take your ARVs. The baby should be tested, and the baby should receive prophylaxis, which is as per the guidelines. For a baby who has been born and the weight is less than 2.5 kgs, the baby needs specialized care, keep warm, feed, take to hospital so that you can get more advice on how this baby can be taken care of. So as families, what you can do, make sure the baby is born in hospital, identify the danger signs, which I have told you about. Be quick to go to hospital once you've identified the danger signs. Take your babies for their vaccinations, go for postnatal visits, and demand for better services. Health workers give the essential care, give health education, assess babies before discharge, listen to the parents' concerns, and update your knowledge, because medicine is always changing, and you need to give the most quality evidence-based care to our patients. Thank you.
Thank you, Dr. Grace. I think that's a great overview of I think you've actually mentioned almost all the interventions that are needed to ensure that our newborns do not die or do not develop illnesses that cause severe morbidity. Thank you for that. And I think for those of you who probably have not been able to follow the discussion, you'll be able to look back and listen to some of the things that our panelists have said, because I think it's very important. As we say every single day on this platform, knowledge is power. And when you know what services you're supposed to receive, then you are able to demand for them. And then that then also accelerates change in terms of service provision, especially for our country that is coming out of a very long duration of conflict. Now, thank you so much to all our panelists for contributing to our discussion today, for agreeing to be part of the discussion, and for all the knowledge that you have shared with us. And thank you for also demystifying some of the things some of the causes and some of the risk factors for mortality in mothers and mortality in children and in neonates. Now, as we come to the close of this session, I would like each of the panelists to give a brief conclusion and some recommendations in view of all that we have discussed right now. So we will start with Dr. Lucy, then Dr. Grace, and then Dr. Alice, and then we will end with Dr. Idioro. So Dr. Lucy, take it away, then Dr. Grace, then Dr. Alice, and then we will end with Dr. Idioro. Thank you.
Okay, thank you, Dr. Anna, once again for inviting me for this important discussion concerning under 5 mortality in our country, which is still one of the major public health problems or a burden to our children. And my conclusion, basically, I will give to our recommendations to the mothers out there listening to us. So let's work together to reduce the burden of under 5 mortality. And I encourage all the mothers out there, please let's take our children for immunization because we need to avoid vaccine preventable diseases. And then number 2, let's have good infant and young child feeding practices. By this, we will reduce malnutrition, and also I encourage on the exclusive breastfeeding in the first 6 months of life, and then we continue with breastfeeding and complementary feeding to reduce malnutrition. Your milk is enough for the child. It has all the nutritious elements, and then it also prevents your child from getting infections like diarrheal diseases, ear infection, and allergies. So let's take it from here. This is what I can say. Thank you once again.
You are muted, Anne.
Dr. Grace, sorry, we
Alright.
would like your conclusion and your recommendations. Thank you.
All right, so my conclusion is just to reiterate all that we've been saying today. The best place for a baby to be born is in a health facility under the care of a skilled birth attendant. Number 2, every pregnancy is different, every baby is different. Number 3, breastfeeding. Dr. Lucy has talked about that. And I think we do need a session on breastfeeding because breastfeeding comes with so many challenges. So we would probably need a lactation expert, just to help mothers navigate breastfeeding. Number 4, danger signs. I've told you about the danger signs. Please always look out for the danger signs. If you are able as a mother, buy a thermometer. It is the one single equipment I can say that can help you in being able to at least pick out some things. So if you have a thermometer at home, you can take the temperature and it can help to calm you as to whether, things are too bad or things are okay. Then prevent your baby from infection. And the most important is cord care infections. Please do not put anything on the baby's cord that has not been given to you in the hospital. Please, 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 please. All right. The recommendation is 4% chlorhexidine or nothing on the cord if the baby has been born in hospital. Another thing is the small baby. If a baby has been born, we probably need to teach you how to identify a small baby, perhaps if they're born at home. But if there's a small baby, that baby needs specialized care because they're at higher risk of dying than a normal birth weight or normal term baby. So a small baby needs to be kept warm, needs to be fed. And finally, for health workers, please examine all babies. All newborns must be examined before they go home. All mothers must be kept in hospital for at least 24 hours after birth before discharge, because that way you're able to pick out some of the problems that happens to children, because remember, as we said, the highest rate of death is within 24 hours in a baby. Thanks.
Thank you so much, Dr. Grace. Dr. Alice?
Yeah. Thank you once again for having me in this discussion and be part of this. As I'm representing Minister of Health, it's a bit something like a big task for me. But what I want to say is in my closing remarks and conclusion is that Minister of Health, a lot of things are expected from Minister of Health. And according to the discussion, there is a lot of gaps needed to be addressed. And for Ministry of Health to work or to cover all these gaps, it needs finance. And financing is a big problem. As long as the percentage Ministry of Health are getting which is less than 2%. And that percentage, if it's not being increased, it's going to be a challenging for Ministry of Health to address all these gaps and all these challenges. But Ministry of Health is working hard with the partners. The policies are there. We have the programs are there. Strategies have been it's been there for quite some time, and also the plans are there. If you want to go to the Ministry of Health, so we get all those documents. But the problem is implementation of those plans, and to implement, you need money, and then you need partners to implement it. That's why Ministry of Health is depending much more on partners to implement. In terms of recommendation, of course, we are the one now to hear to all this discussion and get all these points. So for Ministry of Health, we don't give recommendations. We actually get all the challenges from this discussion as part of what's needed, what Ministry of Health is missing, so that at least we can address it and we can just reduce child mortality and, of course, to reduce maternal mortality, because maternal is the mother and we're just coming after mothers. Thank you so much.
Thank you so much, Dr. Alice. Dr. Idioro?
Thank you. I'm just requesting if I can get 4 minutes so that I address some of the questions. I'm just putting my timer very fast. There was a question about...
Dr. Idioro, I will give you only 3 minutes.
Yes.
Okay,
all right,
thank you.
That's fine. That's fine. I'll just finish. There was a question about somebody who is concerned about going for a scan, and she was told the fetal heart is not there. Losing heartbeat can be from first trimester, that is a miscarriage. We call it miscarriage. And then again, it can happen even earlier, that we call a blighted ovum, because heartbeat usually is available from 5 weeks of pregnancy. So, and even it can go all the way until viability, when the baby is already alive and ready to survive outside. And that one we call it IUFT. And again, like Grace has said, some of the malformation we are not able to pick with the ultrasound during pregnancy. So sometimes a baby is born with severe congenital heart malformation, which was not picked during antenatal care, and then the baby suddenly dies immediately. So this is how we can lose a fetal heartbeat during pregnancy. Again, when a mother delivers a baby and the baby dies immediately, so we take it needs psychosocial support. We call counselors to talk to the mother about grief counseling. Then we also support the breast by giving some medications which will prevent breast milk from being expressed. And we advise mothers not to express or not to press the breast. So, and we give some analgesics. Within 1 week, everything goes back to normal. And I think these were all the questions. So in conclusion, I'm just advising all my South Sudanese women, you need to have your rights, and you need to know where to deliver, and you need to know when to access a medical facility. And home delivery, as Dr. Grace has already said, home delivery is not encouraged. If you ask me to deliver you at home, we'll have to prepare an ambulance. I will be there in your house delivering you, but an ambulance will be waiting in case anything goes wrong. And there is a hospital already waiting for an eventuality to receive you in theater immediately. And that will, all the costs will be incurred on you. So it's better you just take yourself to health facility and the labor being monitored there. Because if the home delivery is never safe, and it will never be safe. I think that is all. And rights to health services, everyone should know. If all of us knew our rights to health services, I don't think we will have that Juba Teaching Hospital like that up to now. That maternity should have been a world-class standard maternity department by now. But because we don't know our rights, that is why we just took it all the way for granted until we are up to now. We are still having that maternity like that. If not for the Chinese, and it is not yet open. So if women know their right, that maternity department will be open by tomorrow. But we don't know our rights. We need to know where our rights fall. Thank you.
Thank you so much, Dr. Idora, and thank you for answering those questions. We might have gone off air without answering them. I think in summary, what we have gleaned from this discussion is that one, knowledge is very important, especially for our mothers in our communities, in terms of what is needed in order to ensure good maternal care and prevent child mortality and morbidity. And this knowledge dissemination is up to us as the community and as healthcare workers to be able to tell mothers what it is that is needed, what services they should look for, and what services they should actually advocate for. And as Dr. Idora has said, if you don't know your rights, then you cannot ask for the services that you should be getting. The other thing is that we have also been able to see that there are quite a lot of issues, according to what Dr. Alice has been able to tell us about issues to do with human resources and access and infrastructure. And the Ministry of Health definitely has a very huge job when it comes to ensuring that the health system is built to a level where it's able to take care of the population as it should. And this is something that will take a bit of time, but we hope to see progress in that as soon as possible. Now, the truth is that health infrastructure and healthcare cannot improve in a setting of conflict or political instability. So we need to ensure that our country gets to a level where peace is what reigns. And when that happens, then we are able to actually put up infrastructure and train our human resources, and even for those who are outside to come home to be able to give the knowledge to our people so that our people can also benefit. So I want to thank each and every one of you for participating in this discussion, for taking your time, for sharing your knowledge, and especially for educating the audience on the danger signs to watch out for, because these are things that they can do for themselves even before they get to the facility. And I think the underlying advice is please, 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 mothers, deliver in a health facility. Deliver in a health facility, and this will prevent both maternal mortality and child mortality, because these two are closely linked. If the child is taken care of, if the mother is taken care of as they should be taken care of, if they're given the advice and the information that they need, then the child has a higher chance of survival. So thank you so much, our panelists. Thank you so much, our audience, for joining us. And thank you, UN Women, for facilitating our panelists in Juba. And I'll also thank Aisha for being behind the scenes and helping us with the streaming of this live video. And I'd like to tell the audience that you can always come back and listen to this discussion. There's so many points that have been raised that are very important, so much knowledge that you can glean from this. And for those who have not been able to listen in, you can share the video with them on all your social media platforms. I'd like to thank my panelists again for coming in, and we hope to see you on another discussion. Thank you so much.
Thank you.
Thank you.